What did you think?
Well, Ashley, to be honest with you, the way the podcast ended with Dr. Abraham, I started getting tears in my eyes because of one certain sentence she said for like words of wisdom for people with IBD.
Yeah, what was that?
That we don't have to suffer.
Mm,
Oh my gosh, I may cry now.
yeah. Yeah. What does that mean to you?
I think like because I know how terrible this thing can be, just hearing, a doctor who has so much wisdom and has so many tools in her toolkit to help people is just a really reassuring thing to hear
Yeah.
when you hear so many negatives about the disease.
Hmm. Yeah. There's so much shame sometimes about and guilt around it that we don't even stop to think about how much we maybe are suffering, especially when you've had it a long time. You just kind of get used to how bad it can feel.
Absolutely, yeah. And you don't know what it's like to feel healthy, I guess, or like you've accepted your new normal. And I, yeah, it was just really reassuring to hear her say, that's not how it has to be. So it was just kind of like, oh, wow. You don't really hear that a lot. Well,
Yeah.
I don't anyway.
Not enough.
Not,
Not enough.
not enough.
It,
Yes.
there's never enough to know that there's something in the way that she said that is so caring and makes you feel seen because she's recognizing how much we do often suffer with IBD and to the degree that we suffer too. There's so many layers to IBD that it's not just about going to the bathroom a lot. There's a lot more to that isn't really talked about. And so we never fully feel seen. But it's nice to hear somebody say that and really acknowledge the the stuff we go through.
Absolutely. Yeah. Not just dismiss it.
Yeah.
Yeah.
So I really loved this discussion. Of course, it was very special for me. Dr. Glassner's podcast and Dr. Abraham, very special to get to chat with them. I've known about both of them for a long time and admired them from afar, and gotten to cross paths with them and worked with them in some capacity too. And so it was just, um, it's just such an honor. It's an honor to have them on, and honor to have Dr. Abraham on and all the stuff she's done for IBD patients over the last 20 years.
Mhm.
And I think it's easy to feel, as a patient, it's easy to feel isolated. Like people don't care, especially if you're, I mean, I've been there in the very beginning where I had mistrust with healthcare and I felt like I was alone in my diagnosis, like no one really got it or understood or cared. And it's so refreshing and nice to see all the GIs we've interviewed on this podcast so far have really dedicated their lives to helping people like us. It's so refreshing to know that and helps me on the other side of all this feel, wow, it's good to know that we're cared about, that and that also that the sense of hope that things are advancing and changing, and that's the real value of research in the space.
Absolutely. Plus, there's just something about girl power that is like
Yeah.
it just makes you feel good.
Yeah, all of these are female GIs,
Yes,
which is rare, but then to have that specialization in IBD is also really cool.
absolutely. And here's not to say like, okay, my GI specializes in IBD. He is a male. He's great, but yeah, I'm a female, and girl power and Spice Girls and all that is something that I'm happy about. And it's great to have that and to have that empathy and understanding from these women.
Yeah.
What did you think of the pod?
Well, yeah, I loved it. I loved that we didn't just gloss over the nutrition part. Like we went more in depth into like how she's conversing with people, how she's navigating these really tough topics, like stuff that we find to be challenging too, like which is discussing that the importance of the dietary component, even if you're not getting symptoms with something, how it can still be harmful longer term. And we talked about all the different dietary trends and the importance of nutrient deficiencies. And yeah, I mean, we could have, that podcast could have been like a 2 hour podcast if we had more time with her, but
Yeah.
it's
And
just a
even
really good conversation. Yeah.
like, I feel like it's a really good like crash course.
Right.
Yeah.
Yeah.
A lot of good, hard topics hit and discussed well, I thought.
Yeah. And I also say it's like such a full circle moment for me too. I read her article very early on in my diagnosis. I read her research. I was like, aha, there's something to this. And that really sparked something in me. And then to see her over and over again through the years and yeah, get to be here where we're talking to her, and yeah, very special.
It was. So, everybody listening today, you are in for a treat.
Yes, enjoy.
Today on the Gut Feelings podcast, we have Dr. Bincy Abraham. She is the Distinguished Professor and Director of the Fondren Inflammatory Bowel Disease Program at the Underwood Digestive Diseases Center of Houston Methodist Hospital. She is also the Program Director for the Gastroenterology Fellowship at Houston Methodist Hospital. She earned her medical degree from University of Texas Medical Branch, where she continued with residency training in internal medicine and fellowship in gastroenterology. During fellowship, she received specialized training in inflammatory bowel disease and earned her degree in Masters of Clinical Investigation. She also completed a National Visiting Fellow Inflammatory Bowel Disease Rotation Program through the Crohn's and Colitis Foundation in Cedars Sinai Hospital in Los Angeles. She has chaired the Southern Regional Chapter of the CCFA Medical Advisory Committee, served as president of the Texas Gulf Gastroenterology Society, is involved in national committees for, and is a fellow of the American College of Gastroenterology, American Gastroenterology Association, the American Society of Gastrointestinal Endoscopy, and the Crohn's and Colitis Foundation. She is trained in and passionate about intestinal ultrasound in IBD patient care. Dr. Abraham, thank you for being with us today. And you are in everything. That's amazing to see.
Thank you for having me. I was so excited when Ashley reached out. I love talking about, at least sharing the wealth of knowledge in regarding taking care of IBD patients. So it's like anytime talking about gut and guts feelings, I'm there.
Yeah. Well, it's nice to have you. And I have to admit, I don't think I've told you this before, but I knew about you way back in 2011 before like when I was diagnosed. And you're actually one of the people who inspired me to kind of specialize because I read some of your early research. You had a study about dietary risk factors in IBD. You were on that. And then I started seeing your name everywhere. And so then when I would start to write about, IBD stuff, I would cite you and I was like, who is Dr. Abraham? And it's just been inspiring and super special when our lives have crossed, and super nice to have you on because you've been an inspiration to me from really the very beginning. So
That's so sweet to hear. You spend your life doing what you do on a day-to-day basis, but I guess you don't really understand the impact that you have on others. So it's really, it just validates, all the work that you do on a day-to-day basis. So it's really nice. And hopefully we can keep inspiring more people out there.
yeah, yeah, it's also really rare to see one first to have a female GI, but to have also have a specialist in IBD, and if it's just like a rare scenario. And I'd love to hear about how you decided to become a GI, and specifically what got you interested in specializing in IBD.
Well, I always like to partially joke, GI in the GI world that it's a dirty job, but someone has to do it. not everyone can withstand, having to do colonoscopies for a living, but we have to do it, right? So I fell in love with the specialty because, well, first and foremost, I'm a medicine provider, right? I love internal medicine, kind of fitting the puzzle of symptoms to disease together, but also enjoy kind of specializing in an area where I can have the most impact. And I'm also someone who likes to do a lot of things, procedures. So I got the best of both worlds, take care of patients in clinic, but also doing procedures and taking out polyps and doing something that's immediate impact right then and there that can actually change a person's life, preventing colon cancer, etc. as well. So I liked that merge of both worlds. And then as far as do a subspecialty, it's so funny in life. Everyone says, "Oh, what do you want to be when you grow up?" Oh, okay, well, I'm going to be a doctor. And then it's like, well, what kind of doctor do you want to be once you're actually in medical school? It's like, oh, I have to decide that too. Okay, in medicine, I want to do medicine. I don't necessarily want to do surgery or psychiatry, etc. And then they ask, well, okay, you want to do this, and I decide to do GI. It's like, oh, what kind of gastroenterologist do you want to be? Like, what? You have to make more decisions. So, I mean, you could be a general gastroenterologist, but I love the fact that I don't know what it was exactly, but I don't know if it's the immunology side of things or seeing patients with a chronic disease suffer, and there wasn't a lot of medications out there when I was first a fellow growing up and learning about all of this. Now we have so many more options, and there's this disease out there that patients were suffering, there was no cure, and I thought, gosh, I really think I can make an impact on these patients' lives. So it just kind of fell into place. I did my Crohn's and Colitis Foundation Fellowship, and it was just like, okay, this is it. This is me. This is what I have to do. And it was one of those, like, I want to say, like, serendipity moments of meeting the right people at the right time. And you realize, oh, this is it. This is what I got to do. And I've never looked back since. It's always been moving forward, moving forward. Yeah.
Wow. Yeah. And how long ago was this that you started that specialization?
That's giving away my training and age, so I don't know. Should I say that? No, I finished GI fellowship back in 2008, so it's a couple of years later
Oh,
that you discovered me. So yeah, I started 2008, and so it's been a couple of decades coming in. Yeah.
awesome. That's special.
It is. And like, when it comes to that, to Dr. Abraham, we, of course, really appreciate it. And one of the things that we do in our practice as well, much as you, reading up to date articles as much as we can. What I've noticed from you is that you've definitely touched on nutrition on some of those articles that you have been a part of. And I'm wondering, like, how do you bring up nutrition with your patients?
Yeah, often I don't have to because patients ask, well, one of the most common questions that patients ask is regarding diet. So, what can I eat? Or did I eat something wrong that triggered me to have this disease? And unfortunately, we don't have a great answer. And one of the first studies that actually I did that you read, Ashley, was regarding the risk factors of inflammatory bowel disease based on diet. And what we did find is that, at least from the studies that we could see and review and put together in a systematic review, was that people who ate less fiber, less fruits and vegetables, had higher polyunsaturated fatty acid intake, had higher risk of developing inflammatory bowel disease compared to those that actually had lower. I mean, they actually, you ate more fiber or had more fruits and vegetables in your diet, you ate healthy in general, you had a lower risk. So we know that diet studies are really hard to come by. And I always tell my patients this, that in a lot of the prior studies that have been done, a lot of the diet studies failed mainly, and quote unquote failed mainly because they couldn't be completed appropriately. So imagine saying, oh, you go and eat this food, and then, oh, you go and eat healthy and you eat whatever you want. Well, the patients who are in the diet that says you have to eat exactly this, this, and this, and be very strict about it. Can you imagine, how many people actually be strict with their diet and follow through without having a snack that shouldn't be eaten, or versus the other group that goes, oh, I can eat hamburgers, I can eat pizza, I could eat whatever I want. Sure, I can stick with that diet. So the strict diet group tends to fail because it's so hard to have patients stay on it. So patients end up coming off the study because they couldn't stick with the diet long enough. I think one of the best studies that was actually done proactively was the one that Dr. Jim Lewis actually did. And here he was the main investigator for this, where patients were actually given meals or already prepared. So it wasn't like they had to go and prepare them themselves. And that was the look at the Mediterranean diet versus the simple carbohydrate diet, and they found no difference. And of course, a Mediterranean diet is so much easier to follow than a very complex diet, and a Mediterranean diet is a healthy diet too. It's lots of fresh fruits and vegetables and high fiber and all the good fats, the good meats, fish compared to red meats, and so on and so forth. So these patients actually did better as far as from their Crohn standpoint, felt better, clinical symptom improvement as well. So in general, diet studies are really hard, but we're getting the same theme though over all of the studies that we do have, is that eating a healthy diet in general is better for you. But you don't have to, have studies to tell us that. Our mom's been telling us, hey, eat your vegetables, right? From the olden days. And unfortunately, it's easy to go to McDonald's or Burger King and get fast food, and all these processed foods are easy. They stay in our pantries forever. You don't have to eat them quickly before they, rot. So it's easy to follow an unhealthy diet and really hard to follow a healthy diet. So that's where this discrepancy of telling everyone to eat healthy and then trying to make that happen in real life is so much more difficult than to, do a study and go, okay, here it is, and here's the answer, and follow through.
Yeah, I agree. There's this balance of needing for the study's sake for it to be rigid, but also for the person's sake, needing like the flexibility and the guidance and all the stuff outside of that for it to be successful.
Yeah, and I'm sure the other side of things, even though we tell our patients to eat, these better foods, patients that have Crohn's disease or ulcerative colitis, when they go into a flare, they're like, yeah, this is great. You tell me all these things, but it's so hard for me to eat fresh fruits or fresh vegetables or high fiber because then I feel bad. So I don't want to eat it. So then what do I really do, right? And this is where I actually recommend, I mean, I do as much as I can in our own clinics to be the dietitian, right? Say, okay, these are things you need to do and you need to eat. But this is where we need all the help that we can get. And this is where we refer to you, Ashley, Danielle, and any dietitian. But the dietitian needs to know, what can a Crohn's patient eat? What can an ulcerative colitis patient eat when they're in the middle of a flare, when they have stricturing disease, when they can't tolerate the healthy stuff that normal populations supposed to eat and can tolerate as well, if we're actually, are they going to be motivated to do that? So a lot of our patients have the motivation, but their clinical health is where it's really difficult for them to actually follow through with that, because they may end up having more symptoms initially while we're trying to get their disease and their inflammation under control, or mechanistically try to dilate or keep those strictures open, or end up having surgery to open those strictures where they can actually eat more normal foods too.
Yeah, that actually was something I wanted to chat with you about too, because kind of what we've seen on our end is this trend towards, there's a lot of I think IBD patients that are more vulnerable to more restricted diets, and even stuff like carnivore diet, which is very restricted to, one food group essentially. And we know, like, from the microbiome perspective, that this is not a great thing for people with IBD. Like, I read one of your microbiome studies too that says with dietary changes, you can see changes in the microbiome in as little as 24 hours. So it's not harmless to try it. And in addition to that, you see changes, by bile tolerant bacteria changes, and increase in some of the things that we don't want to be high in IBD. So it increases risk significantly. But then there's this other side, is like, and I've felt this as a patient before too. When you're first navigating all of this, you're thinking, okay, this causes symptoms, so I'm going to take that out. And then you end up very limited. And so there's this disconnect between, well, this really restricted diet had symptom reduction, but, you're you're telling me it's harmful. How do you talk about that with your patients? Because this is something that comes up a lot for us.
Yeah, so restricting diet can lead to nutritional deficiencies, and you brought up a good point actually, that they may feel better immediately because they're limiting certain things that may have triggered symptoms rather than actual disease per se. But it's not an immediate nutritional deficiency, right? It may take weeks or sometimes even months to develop a specific nutrition deficiency if they're on a specific diet. So in general, it's always advisable to have variations in what you can eat. And this is where you come in to say, hey, okay, this is what I like, this is what I don't like, and this is what I can tolerate. Okay, based on these, okay, then let's see what we can eat for breakfast, lunch, dinner, snacks. So they have something to go by rather than, okay, I'm going to stick with meats only. Well, what about your B vitamins, your, the things that we get from green leafy vegetables? I even had a patient who developed scurvy in these days, and he was not a pirate because they were sticking to rice and chicken because everything else was bothering the patient. So, and they had bleeding gums, things I learned back in medical school. Oh, bleeding gums, we don't really get that. We don't get scurvy. Everything's vitamin C enriched, but vitamin C was undetectable when we checked a nutritional panel. So that these things can actually happen nowadays. It's not like, we're living in the, I don't know, 1500s, 1600s, when were pirates around? I don't know, probably even later than that. But yeah, nutritional deficiency can be a big issue. And the other part of it is that if you already have inflammatory bowel disease, your gut's not working as well. You're already not absorbing as much nutrition as possible because of inflammation, ulcers, and especially in the small bowel, if you have Crohn's disease as well. So in those cases, very important to make sure that nutritionally you're optimized. And in some cases where your gut has been removed, for example, the terminal ileum or the end of the small intestine, where Crohn's can affect a lot of patients, and they get strictures, that area may actually be surgically removed in a lot of patients, and that's where vitamin B12 gets absorbed. If you don't have that segment, you may have a high risk of B12 deficiency. So in my practice, we check at least annually nutritional labs to make sure, iron, zinc, B12, vitamin D, those common things are not deficient. If they are, to optimize them by supplementation. Sometimes oral supplementation may be enough, but if your ileum, if a significant part of your ileum is gone, sometimes you may need to get injectable B12 to treat that, because oral absorption may not be best for that type of patient. So we really have to personalize to that individual patient too.
So you bring up some really good points, and you're one of those doctors that is looking for these types of things. You're aware of the research, you do the research. And there's a lot of people out there though that I think are with healthcare providers that are not aware of this and aren't checking for nutrient deficiencies, aren't talking about diet, and or are telling people, just do whatever you want and it doesn't matter. Do you have any suggestions for people that are in that spot that want support but aren't sure how to advocate for themselves for that?
Yeah. Oh my gosh, this is amazing comment, because this is all about empowering our patients. And of course, our patients are going to be seeing different types of providers. Some may be seeing an IBD specialist, some may be seeing a general gastroenterologist, some may see doctors who don't see a lot of IBD, so they're maybe not up to date on every single up to date information, but that's okay. This is where empowering our patients can be hugely beneficial. So if we can get our own patients, let's say that they're worried about something, maybe some side effects, or they have some sort of symptoms. They're not sure if it's truly from their Crohn's or colitis or something else. Maybe it is a nutritional deficiency. Then I think it's important for our patients to bring that up to the provider, saying, hey, I'm having these symptoms. And the provider can then, assess and see if it's something medical testing needs to be taken place, or they know what the symptoms are from. Or if they do have IBD, if they haven't gotten annually, at minimum annually, some nutritional labs done. And then I think we should have our patients tell their providers. I heard it on this podcast that I should be getting some nutritional labs at least annually. Maybe it could be through their primary care. Primary care providers can order B12 levels or iron levels, folate levels, vitamin D. And actually, vitamin D deficiency is not just a phenomenon in our IBD patients. We're seeing it all across the board in America and perhaps in the world, but at least in the US, because nowadays people are not staying out of the sun because we're worried about skin cancer, right? So everyone's lathering up in sunblock and staying out of the sun, and then we're not getting our normal vitamin D absorption from the sun. We just need about 15 minutes daily to get our nutritional requirements on a day-to-day basis for vitamin D. So I think it's important for anyone to make sure that they get nutritionally optimized. And it's not like I'm telling everyone you take a multivitamin every day. That's another topic of discussion, and just from the general population too. But at least for patients that have IBD, at least to get annual labs and basic things. We get blood counts at least annually. I know that, if you go to a primary care, you get your blood counts, make sure you're anemic, your white blood cell count is good, etc. Sometimes you can have iron deficiency without being anemic as well. So I've seen patients that have normal hemoglobin, so something that we normally check on a blood count, but they're iron deficient. And there might be some clues there. They might have their MCV, which is the size of their red blood cell may be low, but the hemoglobin may be normal. That could be a clue that they have iron deficiency. Unless you actually check iron panel, you won't know. So I think it's important to let our patients know that it's okay to ask, hey, I have IBD, can you please at least get some nutritional labs on me? So basic stuff I get is iron, B12, folate, and vitamin D. And they have other symptoms like chronic diarrhea, that I might get zinc level because you lose zinc, or magnesium levels could be low. Potassium, sodium, all those things are part of a metabolic, basic metabolic profile. So those electrolytes are routinely monitored. So I'm less worried about those because usually primary care can check those things as well.
Absolutely love that you brought all of that up. Thank you.
Yeah, I was going to say I was one of those patients that iron looked okay, but ferritin was a 5 for years. And I've had weird cravings and, the ice and all of that. But then repleting that made a huge difference for how I actually felt. So there's definitely a lot of digging, I feel like, with IBD patients that's different than, a general population.
Right. And fatigue, you brought up that fatigue component of it. And that's a huge thing that we've been struggling to manage in a lot of our patients. Of course, we know that if you have active inflammation, that's a no-brainer, right? You're feeling bad, you're having a lot of GI symptoms, you could be having bleeding, or you're going to the bathroom multiple times, you're having diarrhea, you're dehydrated. Okay, that's easy enough. Anyone can tell why you're feeling fatigued. But we also tend to see a lot of patients who are not having the standard GI symptoms, or they could be in remission. They're healed up. There's no other GI symptoms, but they're feeling terribly fatigued. It's actually a very common symptoms or side effect, or should say, about the disease that we hear from a lot of our patients. Number one thing I always go to is making sure that our patients are, of course, in remission of their disease, number one. If they are, the next thing I actually check is to make sure nutritionally they're optimized, you don't have a specific deficiency, because vitamin D deficiency, iron deficiency, B12 deficiency, all of those things can actually contribute to fatigue. There's actually a study looking at giving thiamine, even without a deficiency, actually helped Crohn's patients with their fatigue. So just supplementing thiamine, which is a B vitamin, can actually help our patients with fatigue as well. And simple things like that can help. Of course, there's other things that contribute to fatigue, having enough sleep at night, stress, taking care of family, work stress, all those things can also lead to, fatigue as well. But, and even anxiety, depression, so mental disorders, and which also can be common, any chronic disease can also contribute. So there's multiple factors to this, but anything that you can actually fix would be beneficial, right? So I may not be able to fix a stressful work situation, but I could find out and treat a B12 deficiency, or iron deficient, like in your case. So I think those are things that we can at least empower our patients to ask for different things, and also to realize that it may not always be active inflammation that contributes to fatigue. If you're not getting enough sleep, that's something a patient can do to work on getting enough sleep, including me. I have to take my own advice sometimes, like, oh, I'm feeling tired. Well, I only got 6 hours of sleep last night. Maybe I need to get some more sleep, and I'll feel better the next day. So it's multifactorial.
Yeah. And something I've been thinking a lot about lately too with fatigue and stress is malnutrition, and how when someone is malnourished, you can actually see decreases in gray matter in the brain and increased rigidity, stress tolerance goes down. And so there's this stress that can come, stress and fatigue, I would say, they kind of go together. They can come just from, not getting enough, which is such a common thing with IBD.
Right. And stress, of course, we know can affect the immune system and thus can also contribute to flares as well. So if you already have the diagnosis of IBD and you're stressed, you were doing well, and the stress can actually trigger a flare too. And I've seen that happen in a lot of patients as well. So I always like partially joke with my patients saying, I wish I could write a prescription saying no more stress in your life. And then everyone will be cured, right? I'm like, I need to write my own prescription for that too. But there's a huge component of that. And there's different ways of dealing with stress, and each of us have our own way, right? Some of us needs to go and socialize. Some others may need to go home and just be by themselves and read a good book. Or sometimes we go to destructive ways of dealing with stress, such as, lashing out on other people, or alcohol or drugs or something else. So I think it's just we have to find healthy ways of dealing with stress. So one of the healthier ways, of course, is exercise. I mean, that's been found to be hugely beneficial and for mental health, stress, of course, even improving your microbiome as well. So I think there's healthy ways to deal with stress, and also figure out what the stressor is and if you can eliminate it. I've even had some of my patients actually quit their jobs and find something else because that was contributing to flares often. Of course, I'm not advocating everyone quitting their jobs, because then who wouldn't be anyone have any work anymore to do. There's always stress in, job, school, etc. And we can't always get rid of family if there's family stress, but there's ways of dealing with it. And sometimes you may need to deal with the situation and directly, but in other cases, it may be trying to find ways of treating that or reducing the stress that we put on ourselves as well.
Yeah.
And you bring up, so many great points, something that is good for everybody listening to slowly add to their to-do list. When we think about other things when it comes to IBD, Dr. Abraham, is there anything that you're most excited about in the future space with IBD?
So obviously, more and more clinical trials that we're doing with different types of mechanism of action agents. It's great because we need as many options for treatment as possible to take care of our patients. And I'm super excited that I'm living in the days now compared to, 20 years ago when I first started, when we had barely just a handful of medicines to treat our patients. We have way more options and more coming as well. Some of the clinical trials or new medical therapies include things like antifibrotic therapy. So we know one of the main complications, for example, in Crohn's disease is strictures and patients having to undergo surgery. Well, if we could find a drug that can actually prevent these scar tissues or strictures from forming, and if it works, I can imagine a drastic reduction in surgeries for our patients. And of course, with better therapies, we're maybe able to reduce the risk of colon cancer, which is higher than the general population or IBD patients. Of course, personally, I'm totally ecstatic about learning intestinal ultrasound and being able to monitor disease activity in our patients without having to put them through colonoscopy every time, because they come to clinic. I can just, do a regular abdominal ultrasound and see how their colon is looking or their small bowel is looking. And if there's wall thickness, I can make immediate changes to their management based on what I see. I can also follow up fast on these patients. You don't have to tell them, oh, we need to do another colonoscopy in 6 weeks to see if you're improving. We can actually just bring them back to clinic, do another ultrasound to see if their wall thickness is getting better. So a lot of these things, just as far as diagnostically, is great. And I think that's going to change how we practice managing our patients as well. And we're actually taking care of educating a lot of the IBD providers out there, and a lot of the GI doctors are interested in learning this so that they can take it out to practice. And I've been involved in training a lot of our providers in the US in learning intestinal ultrasound so they can take it back to their practice and do this on their patients. So US wise, it's been something relatively new. Ultrasound's been a modality of assessing disease in Europe and Canada for years and years prior. So happy to bring this, not necessarily new technology, but new way of using an old technology in taking care of our patients non-invasively with really practically no risk and huge benefit in assessing them. And of course, there's still a huge need. So we're not there yet. I mean, ultimately, would love to find a cure so we don't actually have any more new diagnoses of this disease. But until then, being able to take care of complications, reducing surgery rates, perianal or fistulizing disease is also one of those really tough complications that we have to manage, co-manage actually with our colorectal surgeons as well. If we can avoid or reduce the prevalence of fistulizing disease or preventing that from happening, there's still a huge need. We still have lots of work to do in the research side of things, but I'm actually quite excited that we have a lot of clinical trials underway for managing these patients too.
And do you see in the near future, will patients be on multiple different biologics?
Yeah, so I've been doing combination therapy of advanced therapies for I feel like, yeah, it's been a decade. And that's one thing that I felt like it was lacking. Again, back in the day when we had limited options and if our patients went through all of the FDA approved medications, what do we have left, right? And it's not the patients that had mild or moderate disease. These are my really severe patients. I've had, let's say, multiple surgeries, went through multiple medications, and that wasn't cutting it for them. And what I found was combining different types of biologics or different types of advanced therapies actually helped them significantly. That I saw them really deteriorating, literally starving away from their disease because they're not absorbing the nutrition. They're on IV TPN or parenteral nutrition because just taking things by oral diet was not enough. And after I combined therapies, they became a new person. I had someone who's a young female who was literally like 80 pounds, sopping wet, and on IV total parenteral nutrition and just deteriorating. And we put her on combination therapy. And after several months, I almost couldn't recognize this person because she had meat on her cheeks. She was like, she didn't have fatigue anymore. She was able to walk around normally. She wasn't getting IV nutrition around the clock. And she gained like 20, 30 pounds and completely new person. And it was just heartwarming to see that combining therapy was a way to go. That was one of my first patients back in 2015. We started combination. And since then, I started doing that for a lot of my patients who had the severe disease and one drug wasn't cutting it, and we saw huge benefit. I think a lot of people were actually concerned about combining, oh, there's two biologics, what should we do? Is it safe? There's going to be potential for risk. Actually, we found less risk because we were treating their disease and the patients were getting better. And the combination actually reduced the risk of IV line infections because they were on TPN continuously, and the PICC line infections was huge risk if you're on IV nutrition long term. And we found less risk of infections because the GI tract was healing, so there were less risk of GI tract infection. So we found huge benefit with really low to no increased risk. And now, fast forward, a decade later, a lot of the companies are doing clinical trials in combination advanced therapies, especially combination biologics. So I think that's going to be the new treatment plan where we may end up, instead of having to take 2 injections or 1 infusion and an injection, we may end up having 1 injection that has 2 or 3 different types of medicine in there. They just need to take 1 injection, and it will take care of different cytokines and inflammatory cascades in all different aspects of our immune system, and get our patients, we have more patients getting into remission with potentially no increase in the potential risk of those medications as well. So I think that's going to be the future of IBD.
Wow. So, with that, though, and what you said too, people do feel maybe a little bit nervous to start a second one. When you are someone with IBD and you're starting one new medication or even a second new medication, is there something that you say to them or give any kind of words of wisdom to help ease their anxiety or fear around it?
Yes, yes. So that's a great point, because of course, when you read the label of a medication or you see a commercial on TV, you see people, oh, they look like they're having the time of their life. But in the end, there's always someone in the background with a deep voice going, and of course, with this medication, it's for increased risk of infection, blah, 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 including death. And by the time you're done, it's like, oh my gosh, I don't know if I want to be on it. They look happy, but I don't know. So there's always that concern for potential side effects of these medicines. But what I've learned over since 2008, since Ashley brought it up in my practice, is that I have seen so much more side effects of the disease than I have seen side effects of these medications. Having active inflammation leads to a lot of problems. And I think our patients need to know that if they're suffering from their disease, and it all comes to risk versus benefit profile, right? I would not recommend putting someone with mild inflammation on a very super strong agent with lots of side effects, unless I thought that their disease was so severe that the benefit of the drug far outweighed the potential risk of the therapy. What I'm actually seeing when you look at that seesaw is that having active inflammation puts our patients at high risk of complication from their disease, meaning obviously poor quality of life, from fatigue to going right to the bathroom all the time. They have pain, not being able to go to work or missing out on school. I've had patients who had to miss out on semesters or a year of college because their disease was not under control. It's like, that's not a way to live, right? Or not being able to go out to eat with their friends or go watch a movie for 2 hours because they have to run back and forth to the bathroom because they have urgency. Understanding that there are side effects of having disease is also something to take into account versus a potential for side effects of medication. Now, what we're seeing is that, yes, the older medicines, prednisone, the immunomodulators such as azathioprine, cismarcaptopurine, methotrexate, the old medicines that we used to use, which used to suppress the immune system in general, had a lot of side effects. And I don't recommend using those medicines anymore because the newer therapies are more targeted. Now, I'm not saying that new therapies don't have side effects. There's always someone that will develop a side effect to something. That includes even to placebo drugs in clinical trials. But what we're seeing is that with the newer and newer agents, we're getting more targeted treatment. We're blocking specific cytokines. We're blocking immune cells from getting to the gut. We're actually seeing less side effects to the therapy. And actually, we're seeing more side effects in the placebo arm of the trial compared to the drug arm the trial, or about same side effects between the placebo and the drugs. So we're getting more and more targeted therapy with less side effects. But if a patient's still worried about side effects of medication, this is where I also tell them, look, I'm not going to just prescribe a drug and say, here you go, good luck. Okay, hope you don't have any side effects. I'll see you in 5 years. Absolutely not. We want to start you on something in hopes that this drug is going to work and you feel better. But let's say there's a side effect that happens to the medication. That's okay. Let us know. We'll follow up. We'll bring them back to clinic, a few weeks or months later, depending on how long we need to give the drug time to take into effect. There's also these EMR portals, so patients can send us messages or have any side effects, and pick up the phone and call us, and that we'll assess to see, okay, is this something that we typically have seen with this medication? If it is, and if it's something that's going to go away, maybe we can go along with it. We can, treat those things symptomatically, and hopefully we'll get better with time. If it's something that we know, okay, this is something that potentially could be dangerous, let's go ahead and stop the therapy, then we'll stop the medication and move on to something else. So it's not like this is it. This is not black and white of, oh my gosh, you're going to start this medication and you're going to die. That's kind of worst case scenario. That's not happening. And I also have seen from my experience that the number one reason I actually stop a medication is typically not because of side effects, it's because that drug didn't work for that patient and we had to move on to something else. So I'd say all of these things because what I don't want is a patient so worried about being on a medication because of side effects that they continue with their disease and they're suffering from their disease and they're having daily side effects from their disease when they could actually be normal, heal up, and have a normal quality of life, actually.
Yeah, I'm glad you said that, because I think so many patients go through this period of shame and guilt and just fears about going on a medication. And I was definitely that patient too in the very beginning, where I had lots of fears about that, to the point where it did put me in a dangerous spot. But I seemed okay on the surface. I wasn't symptomatic. And then all of a sudden you're in the hospital for a week and you didn't see it coming. And I think that's the real danger in the difference with IBD that makes it unique, is that, sometimes symptoms are not going to reveal how your IBD is. And, there is a purpose to staying on stuff and monitoring it. And so it's so important that you mentioned that. And yeah.
That is a great point, because on the other hand, I have so many patients who tell me, I don't have a lot of symptoms, so why do I need to be on therapy? So you brought up exactly that. A lot of my patients may not have symptoms. They avoid or delayed therapy, and then something triggers, they're in the hospital next thing and having surgery, or they're for a bowel obstruction, or we find a polyp that looks like high-grade dysplasia that could turn into cancer. So those are those risks that can happen. Even if you feel good, you can still have disease brewing inside. And this is where I find that the intestinal ultrasound, even if you're feeling well, I like to get an annual ultrasound of my patients so that I see how their bowel wall looks without having to invasively go in and do a colonoscopy. There are blood tests and stool markers too, but I find that being able to visually see the bowel in real time, show my patient, hey, look, you're feeling great, but look at this spot right here. This is inflamed. Let's take care of this. I think it's really been hugely beneficial to capture disease early before actually even symptoms occur. Or if you're asymptomatic, to find out that there's something that's brewing before the patient actually has clinical symptoms too. Hugely beneficial.
Yeah, well, I know you have to head out, but I just want to thank you so much for being here and for taking time. Is there any closing advice you have for people with IBD that are in a flare or trying to find a doctor?
Yes. So for all the patients out there that have IBD, if you're suffering, you shouldn't have to suffer. Please let your doctor know that you are having symptoms, or if you don't have a doctor, to find someone that can take care of you wherever you may be, and ask questions. And if we may not always know the answer, but if you don't ask, we won't even know to even assess you for those things. And at at this time in 2025, with so many options out there, there's no point in you having to suffer with the disease. Let us know so we can take care of you. So empower yourselves.
Awesome.
Yeah.
Thank you, Dr. Abraham.